Hello, and welcome to today's webinar, Advocating for Your Program with System Leadership, a primer. Our panelists are Dr. Timothy Graham and Dr. Judith Pauwels, who have prepared an interactive webinar for us today. For some questions, we will encourage you to add your comments and answers in the chat feature. Please utilize the Q&A feature to ask questions of the panelists. Although you may ask questions at any time, designated time has been set aside to answer your questions toward the end of the presentation, and we do not want your questions to be accidentally overlooked in the chat. The recording of this webinar will be available tomorrow on the STFM website at stfm.com/webinars. Now, Dr. Graham will begin today's presentation.
Thanks, Jenny. Well, welcome everybody. My name is Tim Graham. I am the Chief Medical Officer and Designated Institutional Official at Mount Carmel Health System in Columbus, Ohio. And I'm joined today by Judy Pauwels, who will do a brief introduction.
Hi, good morning or good afternoon, everyone. I'm Judy Pauwels. I am a family physician and professor emeritus at the University of Washington. I'm also an RPS consultant and work for the HRSA program development grants to support new program development. I'm glad to be here with Tim.
Right. So as Jenny said, we're going to be talking today about advocacy for your program with system leadership. And as Jenny said, along the way, if you have questions, please feel free to put them in the question and answer section or comments you can put in chat. So disclosures, Judy and I have nothing to disclose from any financial or conflict of interest. And we're going to start out this with a poll question. We'd like to know a little bit about who you are and what is, so this will help us inform the direction we take. So either a medical student, a resident or fellow, undergraduate medical education, graduate medical education, or an administrator or coordinator. And I apologize if we missed anybody else that might be joining us today. All right. So it looks like we are predominantly GME faculty, 74%, although we do have some medical students here. Welcome, medical students. That's fantastic. And we have about 21% administrators or coordinators. So great. Well, welcome. We're thrilled to have you here. So our objectives, what we hope you're going to get out of today's session is by the end of this session, we hope that you're able to just discuss the structure and the roles that are within hospital administration. We hope that you're able to endorse why clear and effective communication is critical to your program success. We want you to equip you with some approaches for advocating for your program with hospital leadership, and also allow you to advocate for getting a seat at the table. So you may ask yourself, why is this important? Well, sponsoring institution support of GME is absolutely critical to what we do because, quite frankly, the relationship of our GME programs to the sponsoring institution is a basis for accreditation decisions by the ACGME. And it really also underpins both financial and operational structures within our GME programs. And quite frankly, the most important and critical element for us having program stability and resilience is really effective leadership. And that's not just program leadership. It's not just, obviously, that's very important within our own individual residency programs, but having a strong and resilient sponsoring institution is also critical to the strength of the program. Also, it's important because there are financial challenges at many institutions across the nation, and this has been for a variety of reasons. Obviously, we just came out of a pandemic, and that took some tremendous financial hits on a number of institutions. Even with some institutions having to close their GME departments, there have been recent cyber attacks. A standard is decreasing reimbursement for institutions from many payers, and as a result of that, a lot of our GME programs are challenged and at risk and threatened for losing some of their reimbursement, some of the financial support that allows us to do all the amazing things that we do in our programs every day. And also, this is important because as program directors, a lot of us really have just not been prepared for this. A lot of us in our medical school training and our residency training, et cetera, do not get a clear insight into who all of the institutional leaders actually are, why those relationships are important, and really how to have that interaction to talk about how important your program is, what your program brings to the institution, and why it is a good investment for the organization to have GME. So we're going to actually ask another poll question. This poll question is asking how you would describe the quality of your relationship between your program and your hospital or your sponsoring institution. So it goes everywhere from very strong with excellent support and regular communications to strong with good overall support, good with the program getting most of the resources they need, but there are some tensions, strained, or a worst case scenario threatening, where you're concerned about the program's future given the current situation. You just get to pick one. So this is a good result. It looks like the majority actually fall in the good category, with the program getting most resources, but there are some areas of tension that are difficult to resolve with irregular communications. We had nobody who rated it as very strong. We had 36% that said that it was strong, and then 14% said that it was strained, and 5% said it was threatening. So this again underpins why this session is going to be important for you. So we're going to talk about Judy. I'm going to turn this over to you over mission, vision, and values.
Great, thanks, Tim. As Tim kind of underscored, this is such an important conversation. And when I've consulted with and looked at programs nationally, and the programs that have been most threatened, I would say money is the common theme, and we'll talk a little bit about this, but the other piece of it is if the program has been marginalized from the institution, where it is viewed as a tack on or something different. Oh, we have learners here, but they're really not part of the institution. You know, they're uncertain of what the importance is to them. It's when there has been the creation of an us-them mentality between the program and the institution. And you can almost assess that for yourself. You know, when you have conversations about the institution, is the conversation, oh, it's them over there doing that to us? Or is it, we're in this together and we are part of a common mission and vision and supporting each other? And you can almost ask that of yourself. How do you talk about your institution? So what I'm going to talk about today is the first step in really trying to shore up and enhance the value of our residency programs and our institutions is to integrate that thinking, where to the extent that it's possible, it's not going to be a complete overlap, but there is overlap in mission, vision, and values between the institution and the graduate medical education programs. And how do you engage those discussions? So next slide. So we won't go into this in a lot of detail, but these are those conceptual questions that I would encourage you when you were doing your annual program evaluation or your annual analysis to do a pause for thought about this. You know, any evaluation is looking strategically is what are the mission, vision, and values that you have as a program? You all have mission statements, you all have your passions about why am I here and what are we trying to do in this community? But have you asked about, and have you really thought about what are those same answers for your institution? What's their mission? What are their vision? What are their values? And for both organizations, your program and the institution, what are the goals and challenges that everyone is facing right now? It's that SWOT analysis, but you do it for your program. But what about the institution? As Tim alluded to or talked about in the prior slide, our institutions are actually under threat right now, financially, from cyber attacks, from pressures from insurances. They also face a lot of challenges. And the more you can understand their perspectives and points of view, so you can talk to them look for where are there alignments between them so that you can really enhance those. And where are there significant differences or tensions? Because those are things to pay attention to about, are there ways of better aligning them or talking about them to make win-win solutions? It's to decrease the us-them mentality, because that's going to be essential to working more effectively with your institution, is to find the alignments and address when there are differences to be able to talk about them in a coherent and powerful way. Next slide, Tim. So this is my poll question for you. To what extent do you feel that there is alignment of your program's mission, vision, and values with those of your organization? And you can define what organization you want. Excellent, almost complete alignment, very good, significant overlap, good, some overlap in general, fair, maybe some overlap, but not well aligned, and poor. We are in totally different spaces. So this is great. Only one person answered poor, and hopefully we'll help you think about this. A few people said excellent, and yay for you. I'd love to have you actually maybe in the Q&A share what's worked for you and how you've achieved that. Most people are in the middle, which is, I think, pretty common for most of our programs, and a fine place to start out from, and then because it gives you a basis from which you can further build to enhance that alignment. So we'll go on to the next part. So this is understanding the institution. So the thought process here is you're looking at that alignment and that interface between your institution and you as a GME program. And in general, and this is based on literature, actually looking at this, there are 4 general categories of things to do your thought analysis with. The first one is, what are the organizational lines of authority and responsibility, both for accreditation and operations? The second is the integration of faculty and residents directly into patient care services. Clearly, that's one of the greater values that we bring. Third is, what about the money, financial accountability? And 4 is process and communications. And the next 4 slides are going to go into some detail about each of these, about how do you analyze that and what questions do you ask to better understand that relationship. So Tim, next slide. So for those organizational lines of authority and responsibility, it's just how does your program fit into the organizational structure, both for the clinic, because for our family medicine programs, our outpatient clinical enterprise is an essential part of our programs. So where does it fit? Is it a hospital-based clinic? Is it part of a medical group? Is it independent and freestanding? Am I an entirely different system and, an FQHC? How do I fit into the organizational structure, both for the sponsoring institution and related to any hospital entities that you work with? And the same for the hospital system. How do you fit in there? Do you have independent hospital services? Do you have just a consultation service? Do you have little presence in the hospital system? Or are you an integral part of providing coverage that's needed for the hospital to actually provide patient services at all? So it's understanding how do you fit in the organizational structure. But there's another place where we fit in many organizations, and that is actually in the decision-making structure of the hospital. Many of our faculty and sometimes our residents are key participants in patient care committees, pharmacy committees, medical staff committees, clinic committees, quality and patient safety committees. Those are important interfaces that are actually not only important for the education of our residents to know how to participate in healthcare systems, but are value added to the organization when we are present and fully participating in those things that are important to our institutions. They need these things for patient care, for JCAHO accreditation. They need our leadership and expertise. So how do you fit into that? And then what are the reporting relationships of personnel? So the program director, the faculty, to whom do you report? So these are actually organizational diagrams that you can create. And Tim's going to go into this a little bit later about looking at actually drawing, if you haven't done it, draw in your organizational diagrams, both for the enterprise itself and for the reporting relationships of individual personnel, it's quite revealing sometimes if you haven't done that exercise to actually sit down and do it, because it will lead to some pauses for, wait a minute, what about? And Tim is going to talk about that more as a specific illustration a little bit later. Next slide. So this is the core of what we do, right? This is who we are as family doctors and as GME Enterprises, is we fit into the clinical services, as I mentioned, both the inpatient and outpatient side. And it's to ask specific questions about that. We're required to do that as part of, our report and ads about our programs. And we'll talk about this more in the values section, but it's looking at the metrics, to what extent we're integrated into medical groups and into the clinical enterprise, because we do contribute significantly. But I will also say, we all know this, that residency continuity clinics have significant operational differences that often create tensions, particularly with for-profit or production-oriented medical groups. And being able to talk about that and analyze that is actually quite important. And to be able to articulate what are the needs of residency continuity clinics that are different operationally. That being said, I think it's also important to acknowledge that metrics and outcomes can be aligned. We should not be separate. We should not be, oh, well, we shouldn't be, achieving the same metrics. They may not be quite as efficient in some ways, but there can be an alignment there. So in talking with medical groups, looking at metrics and looking at, again, how can we best model the clinic of the future in which our residencies are training, by saying metrics and outcomes really can be aligned. And our clinics can be innovation laboratories that model the future of patient care. That's part of the vision of the new program requirements. Is we need to step up, and part of the work that Tom Bodenheimer and a lot of groups have done about how do we create the innovation laboratories in our residency clinic to model what is there in the future and what is really going to be important for healthcare and for outpatient family medicine services. So the more, again, you can think about that as a thought enterprise, really, really, really important. Next slide. The third, of course, is the money. So how does the program fit into the budget structure? One really important question is, to what extent is GME leadership? So this is the program director, the associate program director, the program coordinator, administrator, manager. To what extent do you even get information about your budget? The number of programs that can't get their budget is just always kind of breathtaking and sad. So do you even get that number and that money? And if you do you have authority and responsibility for managing to it? Or is it being done around you and above you? I think part of the dialogue, and this is a whole separate conversation, is the opportunities for improving financial performance, both with enhanced revenues as well as managing to an expense, is actually starting with, do you have accurate information about it? Because it's actually really hard to manage it if you have no authority or responsibility, or you don't even know what your budget is. So financial accountability and understanding how that works in your institution, to start to ask questions about it. And we'll talk about the values conversation a little bit later. Next slide. And the last piece of interaction here is process and communication. So how do you interact with the organization? So what meetings do you have a seat at? Where are you actually talking to them? Do you have regular meetings with the C-suite, with administration? Do you ever present to the board of directors? Do you have any interaction with them? Do you present to the medical staff committee? Who sits on your GMAC? Are the important people that need to be on your GMAC on it? Or are they actually, who knows? So what meetings, what processes, what systems of communication exist? And if they are not robust, that will be one of the, again, future conversations about how to get the seat at the table, and we'll end with that discussion here. And then even if you're there, it's a separate question about what decision-making responsibilities and authorities have been defined and what's actually unclear. What about hiring and firing faculty and program management and clinic management? One of the bigger discussions that often happens is, well, the program does its own thing over here, but I manage the clinic, i.e. the hospital or the clinic system. And that's a problem if the residency program does not have any level of control over its own clinic operations. So are they defined? Is it unclear? And are they in the right hands? So again, these are all questions that are food for thought as you think about the interaction between your institution and your program. So we're going to end this section with a poll question. And this is reflecting on those 4 areas and what I just said. We're actually curious, and this is a click all that apply. Where do you feel like you are doing well as a program related to your institution, and where not? And this is actually just a positive one. Where do you feel that you have clear and supportive structures in the area of organizational lines of authority, integration into patient care, financial accountability and process and communications? And if you don't think you have a good relationship, you can just leave it blank, and that will make a statement of its own. Like, financial accountability is looking pretty sad right now. And we'll give you a little bit of time we have 50% participation, so maybe a few more of you can respond. So that's great. So the way this is playing out is almost all of you, the vast majority, feel like the integration into patient care services is going well and is strong. More than about 2/3 of you feel like there are fairly clear organizational lines of authority, of responsibility. So that's wonderful. Only 1 out of 19 of you that responded felt like finances were clear. There's a statement there, and it's, by the way, that's a really common area to not be clear about. And process and communications, it's interesting that only about 1/4 of you said that that was actually clear. So we'll talk about that as this session goes on. So Tim, I will turn it back over to you.
Thanks, Judy. So what you heard from Judy in that last discussion, there was a lot of discussion about getting a seat at the table, being in the right meetings, building relationships. But in order to do that, you kind of need to know who the people are. I think that in many organizations, there is a certain amount of mystery around who's actually in the C-suite. Some people don't even know where administration actually is in your hospital. And so it's really important to really understand the structure of your organization, as Judy talked about earlier, knowing what your reporting structures look like and what each of the key players within your hospital or within your healthcare system actually are. So these next several slides are going to be talking in general about the various roles within the hospital and what is important to them. So this is an example of an org chart. Now, if you've seen one org chart, you've seen one org chart. They are going to be, the constant is they're going to be different in every single system. Some of the names of each of the positions are going to be different. The reporting structures are going to be different. But in general, it's very important for you to know what the setup is at your own institution. This is a setup within my institution, as an example. So we are my hospital system is part of a national system, which is 92 hospitals across the country. And then we've got 4 hospitals within our system. So we've got a system CEO. And one of the things that's important to look at is that the CEO also has some accountability to the board of directors over the system. So there's always another layer. They also, our system CEO also reports to the overall system leadership as well. Then at the individual hospital level, which depending upon how your system is set up, at the individual hospital level, there's typically a president or COO, a separate CFO, and then you can actually kind of look to see where GME itself actually falls, because GME is going to fall under one of these individuals. In my system, for example, I serve as both a CMO and a DIO, and GME falls under me. So I kind of wear 2 different hats in this particular role. But oftentimes the DIO is somebody completely separate from the administrative leadership or the executive leadership. I also, in the bottom of this chart, it's important to kind of look at the fact that there is also a med staff leadership group. And the med staff leadership group, although it is complementary to your to your executive leadership, it is separate. And it is the governing body of the med staff at the hospital. So it's also very important to know who those individuals are, including the med staff president, the president-elect, and each of the individual department chairs. So we'll talk a little bit about these individual roles in the subsequent slides. So one of the, as I said, each system has a little bit of a different setup, but it's important to know your healthcare system's leadership and kind of what's important to them. What lens did they look through? So, one constant is having a system COO or CEO, and that person, their major focus is really kind of big picture. They've got ultimate responsibility for your system. So they are worried and concerned about resources, overall functioning of all the hospitals within your system, and they have the ultimate authority at the system level. We also have other individuals, which may be called different things in different settings, but for example, there's typically a system chief human resource officer. That's another big picture role. That role is interested in human resources, of course, diversity and inclusion, recruitment, the system mission, caregiver and clinician engagement, social justice, all the important components to maintain the culture of your organization and respectful workplaces, et cetera. You also can have a system chief clinical officer who is typically the person that the chief medical officers actually report to, and they're another big picture person. This person has a kind of a focus on recruitment and bringing high value providers into the system, and usually has a very key role in quality and safety as well. You have a system chief financial officer, and that person actually is responsible for the financial stewardship for the entire system. And there's going to be a little differentiation as we go into the next slide, looking at some of these types of roles are actually repeated at the individual hospital level as well if you're in a large system. And then, as Judy alluded to earlier, you could have some medical groups as well, which may be separate from GME oftentimes. And that medical group will have typically a CEO or president as well, who again is going to be big picture. And they're really focused on that medical group operations, which could be your ambulatory care, it could be some of your inpatient services. The medical group is typically those employed physicians that reside within your hospital, or those employed service lines. Then at the hospital level, again, you typically will have a hospital president, and that person may or may not be clinical. So, looking at my own system, one of our presidents is a former nurse. One of our presidents is a physician, and one of our presidents is non-clinical. So it could be any number of backgrounds. So that's important to consider as looking at kind of what lens they're looking through, what their clinical clinical familiarity is as well. Each hospital typically has a chief medical officer. That person is a physician, and they work with medical staff and serve kind of as a liaison between medical staff leadership and nursing leadership, and may have other roles assigned to them as well. Again, in my particular case, I also serve as DIO, so GME actually is under me. Each hospital also has a chief nursing officer, and that person is the overall authority for the nurses within our system, and that is a very valuable partner to have, because they can actually help create those relationships with our nursing teams, which are important for our residents, for our faculty, for our system. And then each hospital typically will have their own chief financial officer as well. Although we have a system CFO at the individual hospital level, the performance of that particular hospital is really governed by that CFO, and that person has varying amounts of familiarity with the clinical processes. Some of them are very operationally driven, and some are less so. We're blessed to actually, ours is very clinically operationally, is very familiar with operations. Then you can have a variety of other people as well. And I said this is not an exhaustive list. So you could have patient safety risk officers, and those are typically those individuals who look at serious safety events. They can be actually a great resource for you to align with in teaching residents about event reporting and root cause analyses. And this is very important to ACGME as well. They expect us to be able to have our residents be familiar with those processes and know how to report safety events. There is typically a chief human resource officer at the hospital level, which again is going to be a very important component of the culture of the individual hospital. There is a relationship with the foundation typically, so the system will typically have a foundation, and that can be actually another great ally for you in getting resources for community value processes or endeavors that actually could benefit the residency program, and working in synergy with your system foundation can be highly valuable. Then, as I said, there's the hospital medical staff and hospital medical staff leadership, such as the president of the medical staff, who's separate from the executive team. And those are actually really important people to align with as well, because that is one place that is a wonderful opportunity to get a seat at the table. When I was program director, I also served as department chair for family medicine as well. So I was at the table for each of those. As in both of those roles, I met with my predecessor as a CMO on a monthly basis, so that again, I was always in the conversation and always had a seat at the table. And then the health system board of directors, they have a lot of oversight of GME as well. So typically when we do our annual institutional reviews, that has to be presented to the board of directors at the end of after it's been created, because the board of directors ultimately has a stake in what happens within GME as well. So we're going to look at 3 specific roles quickly. First, we're going to look at kind of the perspective from the COO or the president. This is again going to underscore why it's really important to know what's important to these individuals, and where are our opportunities to kind of align with them. What can we do to show that GME is valuable and we can actually help with some of the initiatives and some of the challenges within the organization. So some of the things that would concern a COO, patient satisfaction is huge, and quality, the reliability, because that's the reputation of the hospital. That is, whether you're looking at Press Ganey scores or net promoter scores or whatever your system is on, this is a driving factor in whether people choose to come to your hospital or not. Prudent use of resources, because it isn't an infinite and endless pool of resources. They are looking at where can money be aligned to do the most benefit for the system, for the individual hospital, for our patients, and for our colleagues. They are always interested in operational efficiency. So this is a place where, as residencies, we can show that, our length of stay is better, our readmissions are better. All of the learning to talk that kind of language and show that we are a value added, and certainly not weighing down the system in any way, is very important. Reducing waste, and then strategic opportunities for growth. How can we align as GME to help grow certain areas of the hospital, whether it is the services that they're offering or the reach within the community? There are lots of opportunities there. So again, those alignment opportunities, be part of that operational and strategic objective development, help them develop new services, improved revenue. So kind of being good financial stewards and opening up new services can be very important in that. Coordination of care and services, providing follow-up for some of our patients from the hospital that maybe don't have a family doctor, and being an open access to be able to bring them in and get them connected with a primary care physician, which is at the heart of what we do as family docs. Anyway, we love bringing people in and giving them a primary care home. And then enhanced staffing. So from a CMO perspective, in my role, some of the things that I'm charged with, you look at quality and efficiency of medical care delivered. So we want to make sure that safe care is being delivered to all of our patients. We want to recruit and retain highly skilled physicians. So this is a place that we, could also help with that from the learners that we have that are going through, our residents that are going through the system, and trying to retain them within the system. CMOs are also interested in physician wellness and burnout. And also making sure that there's adequate access to various medical services within the community. So our alignment opportunities, we can help with physician group development, by setting up experiences with some of the system medical group, so that our residents get a feel for what a day in the life within our medical group actually could be, and actually perhaps creating that next generation of physicians to serve our community is fantastic. So as a recruitment pipeline, we are as educators are naturals in being able to help with leadership development training. We can offer to do some of that and help with some of the new physicians that are coming in, helping to do some of the innovative models and really pushing that cutting edge medicine, whether we're doing telehealth or home visits, et cetera. When I think about the pandemic, when the pandemic launched, we were up within a week at my program with starting telehealth visits. And, we actually were at the table again and helping the system going to do this in an effective way to meet the needs of our patients. We can actually also look at how we can help with coverage of various medical services, and also work with medical staff relations. And then finally, the last one we're going to look at is the CFO. And again, by definition, the CFO, as the chief financial officer, is concerned about the money. So really, primary concerns are fiscal responsibility, making sure that we're looking sound on the revenue cycle, reducing expenses, making sure that we're staying within budget, making sure that investments are actually coming back with some sort of return on investment, whether it's financial or service or any number of things that actually, as Judy talked about earlier, aligns with what the mission of the system actually is. Bond ratings, capital sources, and operating income. Those are some of their primary concerns. So where we actually can align with them is, being part of that development of the business plan, making sure that we are good stewards of our budgets, and that if we don't have clarity or transparency in our budget, try to get that. Because if we can speak about what our budget is and show how we're using our resources, it will only help our program, and it will ultimately help the system as well. Looking at volume forecasts, directing the direct operating margins, and then just really some of the green dollar versus blue dollar impacts. So this is a reflection question, realistically. So there's nothing that you really need to answer on this right now, but it's something that we want you to think about, reflect on, considering what your own organizational genogram is and what your critical relationships are in your organization. We'd like you to kind of develop who your key leaders and influencers are at your institution. And then we have a little bit of homework for you, and this is not something you have to do right now, but please take some time to do this over this next week or so, and sit down and try to draw out your organizational diagram. Figure out who your key leaders are, figure out what reporting relationships are, and then try to highlight or circle some of those important people that you need to build relationships with, because that is going to be the first step in really getting that influence and getting that seat at the table. So a couple of just closing thoughts on that from my section before I turn it back over to Judy, is that by looking through these prior slides and really considering some of the things that we talked about, if you understand who you're talking to and what's important to them, that's going to really inform what you say. Because, oftentimes when you're actually in those C-suite conversations, or you actually have an opportunity to meet with one of the hospital leaders, you're not going to have typically an hour to talk to them. You're going to probably have about 15 minutes, maybe 20 minutes to talk about what you want to talk about. So you want to make sure it's very high value and shows that level of alignment. And the one thought I'd like to leave you with is also thinking that you are the only person that can really accurately express how important your program is to the organization and to the community. Most of our hospital leadership is not intimately familiar with graduate medical education. It is a different arena. So part of our job, in order to be good advocates for our program and for GME, is to educate our hospital leaders about GME and why we're important. And so with that, I'm going to turn it back over to Judy to talk about value.
Great. Thanks, Tim. And there's so many important points that you brought up that I hope to emphasize here. This is a very short section on how do you demonstrate the value of your program within your institution. It's actually a specific exercise to develop a values presentation, and part of what we'll end with as a resource is a template that you can use to develop an actual presentation that talks about the value of your program. And the couple of most important points before I get into the detail of this are some of the points that Tim just made. It's thinking about who are the most important people that need to hear this. Clearly, it's the C-suite of your sponsoring institution. It may be the board of directors. It may be the medical staff. It should be your GMEC. Truthfully, I've used to do this internally for my program, for the nursing staff, for the medical assistants, for the other educators, because you often don't stop and reflect about what is it that we're doing here that we're really proud of. And for everyone to hear that, it's just like, wow, look at what happened and look at what we're doing, so that they can all share the pride in what you're doing is part of what can be really hopeful. And the other thing I want to bring up about the influencers piece, Tim talked really valuably about within the organization, what are the important roles, but I want to expand just shortly on the role of influencers. And those are people that are external to your organization who have a lot of influence there. This can, by the way, be legislators, either local or federal. It can be city leaders. It can be business community. That role of foundations that Tim outlined, it can be foundation donors, it can be patients, and how they interact with your community. There are other influencers in your communities, and I will actually say that some of the most important examples I've seen of programs that were threatened with closure that successfully fought it used those other influencers. The legislators got involved, the community got involved, patients got involved. Those were the people that emphasized all of this. So that role of influencers is really, really important. So the values equation for GME is the exercise about how do you demonstrate what are the values that you bring and put it in a way that people can see it, name it, and understand it. Next slide. So in general, in defining program impact, which is how to look at your program as something other than a financial cost center, right? I mean, we look expensive, and that's a whole separate conversation. You can look up resources on the financing of programs. It's a big, big topic. But I'm going to talk about the return on investment for that financial investment. So there are 4 general areas. You might be able to brainstorm additional ones. Be creative here. So service to community, service to the system, physician workforce contributions, and improving the quality of care are all areas that you can talk about and demonstrate. Next slide. So in program impact, most of you responded that, yeah, we're providing a lot of patient care services within our institution. You take it for granted. I'm going to say that you take it for granted that everybody will see and just totally value what you do. And I will say to you that if you don't talk about what it is, people will take you for granted. So talk about it. What direct patient services do you provide? How many inpatients and outpatients do you see? What does your patient satisfaction data look like? And in what ways are you addressing community needs? And these are all things that we provide. Many of our clinics, you may have additional things. Sports medicine coverage, you're covering the local high school and college teams. You're providing the only HIV care in the community, addressing healthcare disparities, providing care to underserved populations. talk about it and present on it and give case examples. This is a great place where stories matter. People relate more to stories than they relate to numbers, and your stories about service to community, give examples, bring testimonials are really, really great. Bring them. Next slide. For service to system, we reference this a little bit. It is somewhat about direct monies, but it's also about the things that aren't so easily measured that actually are important, such as controlling costs, such as avoiding ER overutilization and readmissions, such as being a source for care for underserved patients in your community. It's avoiding unreimbursed care. It is providing community benefit. By the way, any of you who are for nonprofit hospitals, they have this community benefit analysis that they have to do to actually support the continuation as a nonprofit entity. I will guarantee that your clinic is part of it, although they won't tell you that. There is direct downstream referrals and replacement physician costs. So there are a lot of ways, and there have been, by the way, attempts to quantify this, that in some of the other resources that we can provide are ways of talking about the actual financial benefit to some of this. It's real, it's there, it's important to acknowledge it. And if you don't talk about it, they won't hear it. So you need to be able to bring this up. Next slide. Direct service to hospital, or again, the things that we talked about. This is one where I think that the CLARE program, you might all have quite mixed feelings about CLARE. Truthfully, I think CLARE was a great thing because when done well, it is how our GME programs, faculty and residents, provide value and address health system needs that our residents need to be expert in going forward, and where we can immediately contribute to organizations on parameters that they are required to report on, and we have significant value to bring to our system. So use that, and then get involved with local and systems leadership by being, as Tim was referencing, part of institutional leadership positions, be on committees, engage in task forces, work on interprofessional engagement by collaborating with nursing staff and other educational systems there. These are all services within your institution that will be valued when they are done well, and when you demonstrate the willingness to be at the table for them. Next slide. I have not ever seen an institution where this is not the number 1, 2, 3, 4, and 5 reason why they support your program at all. And it's because they want your graduates. So being able to demonstrate that you are providing graduates for the community and for the local region and for the state, that are familiar with the local environment, committed to the community and institution, helps them reduce recruiting costs. Even if they're going regionally, there are catchment referral patterns where they can refer into your institution. That's real. Regional reputation, as Tim alluded to, enhanced recruitment of physicians coming to your community who want to teach. There are a lot of places where they may need to recruit specialists here or whatever, and they're having trouble recruiting. There are a lot of people that want to come to a place that is an educational institution and a teaching health system because they want to teach, and it diversifies their jobs and makes them more exciting for them. So all of these things, and then community and civic leadership and your role in being visible in the community is actually really important. Highlight it. And then in the area of quality of care, the learning environment, I'm sorry, could you have next slide? Sorry about that. Enhancing the adoption of new knowledge, having GME rounds and didactics presentations that you can open to the rest of the medical staff and to other, other members of the healthcare team, bringing innovations, demonstrating regional CME, patient care initiatives. We're required to do them. Let's highlight them within the institution and make a win-win solution there. And then bringing new research. So we have a huge ability to bring an impact on enhancing quality of care within our institutions. Let's talk about it and present on it. So next slide. So as part of the values equation, you do need to address the money. I won't go into that right now. There are some separate webinars that are available that were referenced on getting into the money. You do need to talk about it as part of the return on investment, but I think this is the part that they tend to over-focus on as the only thing that's important. when it's the return on investment. It's the whole picture that's actually important. So next slide. So have a presentation of preventing your value equation to talk about all these things. Don't shy away from the financial discussion, but recognize it is only one piece of this overall conversation. And then the last one is to think about who you're going to present to. And I would really encourage you to think creatively about this. Your board of directors, your C-suite, your medical staff, your own staff, the into the community, bring it to your Rotary, think about how to put it in your local newspaper. I don't care, think broadly and creatively about how to get the word out about how valuable your program is. And as Tim said in one of those slides, the most important part is for you to believe it. Sometimes I think we hear so much negative feedback about us as a cost center, and oh my God, I have to justify my value, that we stop believing in ourselves. I think one of the most important reasons to do the values discussion and to demonstrate all of that is for you to believe strongly in yourself and that we are valuable and to have that confidence. So the poll question to end this one is, to whom have you presented, if any, and just don't answer if you haven't, to whom have you presented a values presentation within your organization currently? So board of directors, senior leadership, med staff, GMEC, community partners, or any other, and feel free to put it in the chat if you've done other things. So maybe we'll just give a minute for a couple more responses. So most people who have responded said that they have done senior leadership. Only a few have done board of directors, and I know that access to the board of directors can sometimes be difficult, but it's one to advocate for. Medical staff, that might be one to actually enhance and think about because they can be your allies here. So that may be an opportunity here. And I think your GMAC almost needs to hear it because if they're running your program, they need to know about your program. And then community partners, again, I think are a big opportunity. And one person, Alex put in outpatient leadership committee. That's another great one. So again, think about putting this out in multiple venues because they all are important to hear about this. So I'll turn this back over to Tim to wrap up.
Great. Thanks, Judy. That was a lot of really important information. And, honestly, talking about the big picture, I love the way that Judy talked about the whole package. It isn't just the financials, it's everything we bring to the table. But we need to be able to communicate that. And I think that a lot of times as programs, we don't always tell our stories well. And we don't always tell our stories to the right people. So these next few slides are just going to really kind of talk about some of the things that we can do and what our priorities should be as we're trying to tell our story. So things we should do, we need to know the language of finance and operations. It feels like it's this whole other thing, this whole other domain, but finance and operations, they speak their own language. You do need to understand budgetary terms. You need to understand length of stay. You need to understand the implications of all of these different terms so that you can communicate with them in their own language. They're going to really respect us and partner with us better when we come to the table prepared to communicate with them in a way that they understand, in a way that they value. And one of the things that is noted here is being multilingual really leads to influence and relationship, and that will lead to knowledge and power. And really learning the language of power is necessary, not necessarily that you need to wield power, but instead that you can be really cognizant of it and understand where power is and what the impact it can be on your program. So our priorities as we move forward, really checking the organizational pulse on a regular day, make frequent rounds, and with that, and have meetings with key leaders within your system. Just like I shared earlier that I met on a monthly basis with my CMO at my hospital. That was a wonderful way to get a feel for what was happening in the organization and really kind of get my mind going about how my family medicine program fit into that big picture and to brainstorm over what I could do to be part of the solution. So meet with program advocates regularly, and also some people who may not value GME as much or not know as much about GME. Those are some of the people that you really must kind of win over, and that can really be advantageous as you build those relationships. Have schedule these meetings ahead of time. Have an agenda when you come in, know what you need to say, because again, like I shared earlier, most of these meetings are going to be pretty short. It's not like you're going to have an hour with under most circumstances with any of the key leaders. But make sure that you got your priorities outlined and you come looking prepared and ready to share what either what your asks or your information to share actually is. And as I said, be part of the solution rather than being perceived as part of the problem. So you can also create some leverage by looking at what you can strategically do to help with some situations that the organization might be having, gaps in coverage or different community services that maybe your clinic actually would have, like Judy shared earlier, whether it's sports med or something else along those lines. There are lots of ways that we can share what we could do to make a difference, and then make sure that you kind of follow up and write down what you guys have talked about when you've talked with senior leaders, because it's easier to come. They have very busy schedules a lot of times, and they may not recall what you talked about. So either a follow-up email or just really keeping some contemporaneous notes with what you talked about is really important when you have to revisit that. Check your own pulse. You really should be, as Judy went into wonderful detail about our mission, vision, and values. We really want to know where our mission, vision, and values are with relationship to our system's mission, vision, and values. As a program director, my faculty and I would revisit our mission statement for our program on every 6-month basis, and we would look at it in the lens of our organizational mission statement and our vision and values, and make sure that the alignment was there. It's not exactly the same, because obviously within GME we've got different we're going to have some different areas that we need to focus on. We want to make sure it's still compatible with what's happening at the organizational level. Expect change, and sometimes change comes fast. COVID taught us that more than anything else. Change does happen quickly. And one of my favorite quotes from John Kabat-Zinn was that you can't stop the waves, but you can learn to surf. That is really the skill. You need to learn how to be able to be flexible and how to be able to adjust to change. And then have some friends that or a few friends that can actually spot check you and really be able to give you some candid feedback on some of your ideas, and who can give you some support as you need it. Do not work in a silo. There is nothing good that comes from being in a silo. As Judy shared earlier, honestly, we are stronger when we're actually integrated into the system. Actually, both parties are stronger. The system is stronger with a strong GME presence, and GME is stronger with a strong alignment with the system. And then also just remain emotionally neutral. Be mindful. Take a breath, observe, and try not to be reactive. Nothing can tank something that you're trying to accomplish than coming in reactive. So take a breath and be in the moment, and don't feel like you need to respond necessarily immediately from your emotional core. Take home points. We're going to go ahead and do this and then lead into some questions. It's critical to know who all the people within your who are leaders within your healthcare system are, and that's critical for you to be able to get them to advocate for you and for you to advocate for your program. Just like I said, don't work in a silo. Know the value and strength of your program. As Judy said, sometimes we have to believe in ourselves first. Once we believe in ourselves, then we can communicate that message to the influential people that we need to communicate it to. Speak in a language that hospital leadership understands, and then look for the opportunities to get a seat at the table, whether it's being on a committee or being part of med staff. There are opportunities there, and don't be afraid to branch out and get into that other space. And so this one is going to be one that we're going to allow some chat. If anybody wants to share, just saying what specific steps would you take as a result of this session to work with your institutional leadership? And it doesn't have to be long. We just are kind of curious coming out of this. Is there anything that you've gotten as a take home that you would like to do at your own institution subsequent to this? I don't see anything coming up in my poll right now. Judy, I don't know if you can. Oh, it timed out. Okay. Very good. Well, we're going to just, since we are actually at time, I just would like to allow maybe just 2 minutes or 3 minutes just of us to go over just a little bit, just to see if there are any burning questions that anybody has that they'd like to ask Judy or I before the close of this. And I apologize that we're right at time.
The one chat, thanks to Alex Verdick for this, is teach our educational leaders to do an elevator speech. So
Yes.
the elevator speech is a great idea. So thanks for bringing that up. Yeah, I know this is a lot of information and pretty overwhelming. So I think it's probably a little hard for people to react in the moment, but hopefully it gives you pause for reflection as you move forward.
Oh, thanks, Rick. I appreciate. I'm glad you liked it. And Angela asked if there are any tips on how to create an elevator speech.
It's a great question, Angela. Thanks for bringing it up. The way I would suggest doing it is starting out with creating your values presentation and then picking out the key points, one or two. Remember, your elevator speech is, like 20 words maybe. So just know what are the most important things that are the highlights of what you bring to an institution so that you have it in your back pocket. And it's just picking out the things that you're most proud of, and stories. Have a story or two. The stories are always what sells things. So if you have one or two just great stories, even anecdotes that your residents or students bring forward on something recent that happened, those can actually be great.
Yeah, and I think to that point, making sure that you invite one idea is to invite your senior leadership to your GMEX with some on a regular basis. So at our GMEC, we have representatives from each of the hospitals there, which has been absolutely fantastic because they get to hear all the fantastic stuff that we are actually doing in GME. And it's not a meeting goes by that I don't get some text from my senior leadership peers saying how much they love GME. But this was part of it is letting them know kind of what is happening in this arena. All right. Well, I think we are over. I don't see any other questions kind of coming through right now, so I think we'll draw to a close. Thank you all very much for your participation and spending your afternoon with Judy and I. This is something that we both feel really passionate about, and I think this is just such an important topic for all of us to be really well versed in. And in order to be able to help our programs to grow and to help us to move our program to the next level.
Yeah, great. Thanks all of you for being present. Thanks, Tim, for a great presentation. And by the way, after this, there is a resource slide that will link to both we're going to post on STFM the template for doing the values presentation, as well as some links that you could follow to find some additional resources on this and on financing and on other things. So look for the last slide in this presentation. And thanks everybody for being here.
Thanks, everyone.